and also for the accomplished surgeons, because there are many practical points which are discussed during this presentation. I welcome Dr. Mazhry, and I thank him for conducting this course at the weekly seminar of Jinnah Hospital, Lahore. Thank you very much, sir, and please start.
Bismillahirrahmanirrahim. So we are glad with second part of our Phaco Cataract Basics and Advanced course, Minimizing Surgeon-Induced Errors and Role of Non-Dominant Hand in Phaco Cataract Surgery. In the first part, we were basically discussing the phaco-dynamics, the fluidics, and the topic was know your machine and the patient. And as a tradition, there is a little Urdu poetry in the beginning as well. I'll try to translate it. The poem name is Dastan-e-Chaman. ऐ गुले नाज़ां चमन की दास्तां हमसे सुनो, ताक में हैं बिजलियां बर्बादियां हमसे सुनो. This is story of the garden, our own homeland. झूठे किस्से अजमतों के कजकुलाहों से सुनो, कड़वी बातें तल्ख यादें और फुगां हमसे सुनो. दंदन आते ही रहे किरदार के कातिल यहाँ, रुसवा किए बोसिन मुरब्बी मेहरबां हमसे सुनो. जाबिरों से आमिरों से गासिबों से साजबाज, मुजरिमाना सरगुज़श्ते काजियां हमसे सुनो. मादरे मिल्लत को भी बख्शा नहीं सालार ने, माँ को दी जो जिल्लतें रुसवाइयां हमसे सुनो. नजरियाती ममलकत कैसे टुकड़ों में बटी, सियासी मोहरों से मिले जब पासबां हमसे सुनो. आमिरों और मुनसिफों ने मिलके किए जाद जो, ज़रूरतों के नजरिए खुदगर्जियां हमसे सुनो. ला इलाह के नाम पर जो पाया खित्ता ए ज़मीं, है कुफ्र और तागूत उस पे हुक्मरां हमसे सुनो. मुँह छुपाती है सदाकत सीना ताने है दुरूग, मुनाफिकाना साजिशें और बाजियां हमसे सुनो. ऐ गुले नाज़ां चमन की दास्तां हमसे सुनो, ताक में हैं बिजलियां बर्बादियां हमसे सुनो. So objectives of the today's activity are, on completion of this activity, our participants should be able to define and identify surgeon-induced errors in phaco cataract surgery. And the participants should be able to describe pre-op, per-op surgical strategies to minimize surgeon-induced errors for better and safe outcomes in phaco cataract surgery. And to achieve these objectives, we have divided our discussion in two parts today. In part one, we will be discussing surgeon-induced errors and how to prevent it. And in part B, there will be a video showing and stressing on role of non-dominant hand in phaco cataract surgery. Surgeon-induced errors. First, I am going to discuss the planning errors, which we miss in pre-op evaluation and proper planning, which can always end up in disasters, especially for beginners. And the planning and evaluation, it always starts. See, this is a general sequence which we use in ophthalmic examination. We move from external look of the patient, face, orbit, adnexa, to the globe, conjunctiva, cornea, anterior chamber. Same sequence I have followed here. In lids and adnexa, there are few things which must be ruled out. And there are few negative things which I will keep on stressing, which need to be documented. For example, in history, you ask, and you always write, non-diabetic. Because generally you write the findings which are positive. But there are few negative findings which you should document as a resident and make it part of your practice. because if you make that documentation of negative findings part of your practice right from initial years, then you are bound to commit less mistakes, because while writing you will remember that I have not checked certain things. For example, I am evaluating a patient with the history of diabetes mellitus for 20 years, and on examination there is no diabetic finding, no microaneurysm, no edema. But in fundus examination, I'll ask my resident to write it down. No diabetic retinopathy noted, because it is mandatory in that patient to document for other specialties as well that we have thoroughly examined the fundus and no diabetic changes were noted. Similarly here, the first no which we write in a cataract patient is no blepharitis, no discharge, because any infection in and around the eye can compromise your results, can end up in that disastrous complication of endophthalmitis. In any intraocular surgery, there should be no blepharitis, no discharge. Then the second thing which is very important as long as planning for cataract surgery is corneal clarity. If the cornea is opaque, probably it is a job of some senior surgeon to operate on that patient. And generally these decisions are made on paper, on the list or on the files. The consultant or the visiting surgeon on that day may not have seen all the patients. If the residents and the junior staff has documented all the findings well, it will be easy to allot the cases. And that also shows whosoever is going to operate must have examined the patient thoroughly at slit lamp. That is a part of planning. Second, in corneal examination, the most important thing in anterior segment is, what is in your opinion the most important thing in anterior segment as long as phaco cataract surgery is concerned? Which structure is the most important anatomically? Endothelium. Corneal endothelium is the most precious structure inside the anterior segment. So you have to document how much there are endothelial cells by which you are starting. The test, ideal test for that is specular microscopy, and it calculates density of endothelial cells. The normal is 3000 to 4000 cells per millimeter square. And the cornea will decompensate at what level? If it is less than 1000, compromise starts. Less than 700, it will be difficult to keep the cornea clear. So if you don't have specular microscope, what is the other alternative? A simple one, that is known as specular reflection test. It is a very simple test. You just ask the patient to look into a direction so that the illumination beam and the viewing microscope, the visual axis of the patient should bisect illumination beam and the viewing microscope, so that the incident angle becomes equal to the angle of reflection. So you will be getting maximum light into the microscope and into your eyes. And then about a 1 millimeter wide slit, you focus it on endothelium under high magnification, and what do you observe? Whether it is smooth or there is some orange peel appearance, like sandpaper appearance, that is known as gattata. So the second negative finding which needs to be documented is no gattata, no blepharitis, no gattata. Then we come to iris and pupil. We have to rule out uveitis because the plan will be all different, whether there are synechia or not. And a simple thing, whether the pupil dilates or not. And if it doesn't dilate, what's the reason behind it? Whether the patient is on some hormones like Cardiora or some other medication, or it is pseudoexfoliation syndrome, and whether it is iris floppy syndrome. So all these things will change the plans, and whether the pupil is not dilating because of chronic use of glaucoma medication like pilocarpine, and whether this pupillary limitation or constriction can be overcome pharmacologically, or you need some devices. If you have not seen it and not documented it well, how will you arrange iris hooks or pupillary dilating devices? The simple thing to dilate the pupil is diluted adrenaline solution during the surgery, 1 in 10,000. And if you are sure that this pinhead pupil is not going to dilate, then you need a device which is known as iris hook. So, no uveitis is the third negative finding. And then a positive finding is whether pupil dilates well or not. And then you have to grade the cataract. As I mentioned before, the ideal cataract to emulsify is not too soft and not too hard. Too soft cataract is difficult to crack. It will give way. You know the vacuum which we discussed in our previous discussion, the vacuum builds up only when the tip is occluded. If cataract is too soft, it will be difficult to build that vacuum. And if the cataract is too hard, you will be needing extra phaco energy, and the risk of corneal burn and endothelial damage will increase. So you have to know what is the grading of the cataract. 2+ or less than 2+ is the ideal cataract to emulsify. Then maturity of the cataract. If it is relatively dense cataract, which kind? Whether it is hypermature milky cataract, the approach will be different. We have 4 categories in our this Phaco cataract course. The category 3 is Phaco in difficult cataract. We will be addressing all these difficulties there. But all this planning starts in pre-operative examination room rather in OPD. And whether it is hypermature milky cataract or hypermature dense brown cataract, because all these things will make your planning different. And another very, very important thing to observe, and which has ended up in havoc, in a very serious complication, that is presence or absence of iridophacodonsis. Why is it important? Why is it important to rule out iridophacodonsis? Anybody? To assess the integrity of zonules and capsule zonular complex. Because if we are not aware of that zonular weakness, presence of pseudoexfoliation syndrome, as the moment you take your phaco probe in, the whole complex will sink. And that's one of the nightmares in phaco cataract surgery. So the story actually started by not documenting and examining this important finding. Because if there is zonular or capsular compromise, the technique is all different. We can still do phaco, but we will discuss in our third category of phaco difficult cases how to handle, with the help of tension rings and other things, this zonular and capsular compromise. Then we have to know and explain to the patient the visual potential. What do we expect out of this cataract surgery? We have not examined the patient well. We have not even examined the relative afferent pupillary defect. So no blepharitis, no catata, no uveitis. And here is another no. The first one actually. No RAPD. No relative afferent pupillary defect. A simple test. Swinging light reflex. There is a big RAPD positive. The cataract is dense, hypermature. But with our knowledge of physiology, we know that the amblyopia and the maturity of the cataract and the media opacities seldom cause positive RAPD or does not cause RAPD. Relative afferent pupillary defect, if positive, is indicator of optic nerve compromise or is an indicator of retinal detachment of more than one quadrant. So a simple flashlight test and we know that the outcome is going to be compromised in this patient. You have done excellent surgery. IOL is in place. And the patient has spent 25,000 rupees but cannot see. Now you are telling on the day 1 or day 2 that your optic nerve is not functioning, your eye is not connected to the brain. But the crying patient will keep on kind of advertisement board, the patient will come because the doctor did not explain it before. Why didn't they tell me? And they made me spend 25,000 rupees. And then they are telling that back of your eye is not functional. So never miss RAPD in cataract patients. Document it. No Marcus gun sign or no RAPD. Then if possible, we have to perform dilated fundus exam. That will give us two information. One, whether the pupil dilates well or not. What is the type of cataract? Whether it is, you see, in cataract classification, we have to document whether, I missed in that slide, whether it is posterior subcapsular type, whether it is posterior polar type. Because posterior polar cataract, sometimes it already carries a capsular defect at posterior pole. So it is very important, dilated cataract and vitreoretinal exam rather. Even if the cataract is hypermature and you don't expect that you will be able to see retina, still this dilated anterior segment and fundus examination is of utmost importance. Then during your interaction in OPDs and in pre-op rooms, you have to know what's the behavior of the patient. How does the patient behave to installation of Midressal eye drops, to installation of alkane eye drops? What's the behavior of the patient during biometry? That's where I decide. And there is another test which I sometimes do on table. My OT staff knows it. I call it alkanization test. He comes up with alkane eye drops bottle. I just open the lids with my thumb and finger, index finger, and we instill the drops. If the patient is not squeezing and is comfortably looking straight on the ceiling, the patient is a good candidate for topical anesthesia. If the patient is squeezing, the answer is simple. Needs retrobulbar anesthesia. So this is what you need to document and plan beforehand, because wrong choice of anesthesia can end up into a big disaster sometimes.
What about amblyopia?
Amblyopia, that's where we will come in the history, refractive history. If you expect amblyopia, the only thing is to explain to the patient that the outcome may not be that good. That only you can know with the history of previous classes and during biometry if there is any difference in axial length. We will come to that. And similarly, in pre-op evaluation, you have to know how is the globe, the eye, placed in orbit. We have got oriental eyes, generally deep set. So 12 o'clock approach is not ideal for Oriental eyes. One has to learn temporal approach, because even in experienced hands, if the surgeon is stuck to 12 o'clock route, it can end up distortion of eye, because the probe makes your phaco probe almost vertical. And from 12 o'clock, all the instruments which you take into the eye are angled, but we cannot angle the phaco probe yet. So that's why it is important whether it's high brow, how is the orbit, and how deep set is the eye. Sometimes the patient is quite cooperative, but the eye is sunken. So I'll ask my assistant, I would like to inject some local just to proptose the eye a little bit. The prominent the eye is, the better it is for a beginner to perform phacoemulsification on that. So these were the planning errors. Then we come to the measurement errors. Biometry is a very important thing. As I mentioned in my previous discussion, that the cataract surgery has become a refractive surgery now. Gone are the days when patient was hand motion or PLP or positive, could not count fingers preoperatively. With dense cataracts, the surgeon takes it out in toto with ICCE, and next day they have not implanted any lens. They remove the bandage and they show how many fingers. The patient says 2, 3. Congratulations. So now this is not the time. Now you have to check the VN, and the expectations of the patients are very high. The 6/6 is the kind of thing which every simple man from the village knows, that I have to read the last line in next day or next to next day. So that's only possible if we are careful in our measurements, and our target is to achieve emetropia. How can we do that? The spherical error is going to be corrected by the intraocular lens itself. But if there is difference between keratometric readings, and there is history of use of astigmatic refraction in the past, and there is difference of refraction between two eyes, that's where the amblyopia comes into the picture. And if there is difference between axial length of two eyes, so this major target after phacoemulsification, excellent phaco has been performed, but a miscalculated IOL was implanted. The patient is again unhappy because the patient cannot see. The patient actually is not concerned which phaco machine you used, whether you used divide and conquer or phaco chop. The patient has nothing to do with it. Ranjan yaar tabib suninda, main tan darda walle. Patient is concerned कि मुझे मिला क्या? What is the visual outcome? The visual outcome is dependent on these biometric issues, and I am not going to repeat much things because I know Professor Sohail Sarwar, a master of diagnostic ophthalmology, has already taken a session on biometry. And we know all these techniques, the manual, ultrasonic based, then laser interferometry based, which is known as optical biometer. If there is a astigmatic component, then we have to document which one is the steeper axis, because our recommendation and intention will be to place our incisions on steeper meridians. That's only possible if we make it a habit to document the K reading along with its axis, because most of the biometers, they just take the average and don't show the axis of the keratometric readings on the printouts. So if there is astigmatism, then we have the option of toric IOL, or we can by placement of incisions, or there is another interesting technique which I use in up to 2 diopters of astigmatism, that is known as double Phaco knife pass, dual incision. You make your one incision of 3.2 millimeters knife, and just opposite to that, you give another pass in the end, and coupling effect, you can get relaxation of about 1.5 to 2 diopters with this simple maneuver. Then there are limber relaxing incisions, though they are not very predictable. What are the sources of error in keratometry? तो थोड़ा सा ग्लिच है, आप थोड़ा सा वक्फा कर लें, क्योंकि हमने अपनी इंटरनेशनल ऑडियंस को भी साथ लेके चलना है ना. हेलो, इधर से जा रही है नुमा. होपफुली जा रही है, आप खुद दोबारा कनेक्ट कर लो. Sources of possible error in keratometry are poor fixation, because we have to take the central reading. The patient is not fixating well, we can take an erroneous reading. And other corneal problems, simple thing, if the patient has some dry eye, you are going to ask, look into the target, and the blink rate is going to fall. If the dry spot appears, you will get erroneous reading. So we have to take care the tear film is healthy and ask the patient to blink. And if there is prior keratorefractive surgery, it is all different. We will if the scarring nodules, then we can consider this rigid gas permeable over refraction, or we can take biometric readings from other eye. Then there are calibration issues. Off and on, we need to calibrate our instruments like keratometer and Hogstite tonometer. There are always there the calibration instruments. So once a while or once a month, the residents should know how to calibrate these sensitive gadgets. Then there is a thing which I found very interesting, contact lens holiday. See, if the patient is a contact lens user for biometry and for refractive surgery, for LASIK and femto procedures, you have to discontinue contact lenses for proper topography and proper keratometric findings. It can give rise to contact lens warpage as well. So ask the patient for a contact lens holiday before performing biometry. 1 week, 1 to 2 weeks. Then if you देखो Similarly, as we noticed in case of keratometry, in case of axial length measurement, the poor fixation may be another issue. Then we have to know if the patient is myope, there may be some staphloma, and you may need again laser interferometry based optical biometry. And the very simple error which residents do very frequently is compressing the cornea. You know, from our classical teaching, the formula for IUL in the manual calculation is 0.9 into K minus 2.5 into AL. So that shows one diopter wrong reading of keratometry will end into error of 0.9 diopters, and 1 millimeter of wrong calculation of axial length will end up into 2.5 to 3 diopters away from emetropia. So you have to be very careful, because this is a general tendency to compress the cornea that gives rise to shorter axial length measurements. So for that, we have to have a look tangent to the eye. Your visual axis should be tangent, so that your probe goes towards the cornea. You can see their interface, whether it's compressing the cornea or not. So your eyes should be right between your A-scan probe and the surface of the cornea, and you should be able to visualize this contact and make sure that the cornea is not being compressed, because it gives rise to shorter axial length measurements and erroneous biometric calculations. Similarly, in dense cataracts, you may have to increase the gain of your machines. Siliconized eyes also need special measurements, and optical biometry is generally helpful in these situations as well. ज़्यादा लेंथ शो करता है तो उसमें भी फिर हम ऑपोजिट आई को कंसिडर करेंगे अगर मैनुअल बायोमीटर है. Otherwise, optical biometry with IOL master or hug straight is a kind of solution for in these situations. And again, you have to explain, in spite of all these careful measurements, in these unusual situations, there are chances of error. So we have to explain it well to the patient. So this is very important slide. One, always measure both eyes. If Allah has blessed with one as a control, we are going to operate one eye, but always measure two eyes. And then if repeat keratometry, if there is of between two eyes of more than 0.5 diopters in keratometry and more than 0.5 millimeters in axial length measurements. If there is difference, if you have calculated it on an automated instrument, please do it on. These common pitfalls and errors will be detected only if you make a habit to measure always both eyes. If the axial length is less than 22 millimeters, again repeat. If axial length is more than 25 millimeters, again delete the data and repeat. And if there is difference of axial length of more than 0.3 millimeters, the lesson is repeat the axial length and ask some senior to come into the picture as well. And then always clinically correlate, as Dr. Naeem pointed out, because if there is difference in biometric readings and in axial length, one of the eye may be amblyopic. So better to ask the history and better to ask about the glasses patient had been wearing all of his life and explain and expect the prognosis accordingly. In IOL formulas, the first and second generation have been ditched already, so I'm not going to discuss. The third generation, Holiday is good for 24 to 26 millimeters, Hoffer Q is good for shorter axial lengths, and SRKT is considered good for longer axial lengths. And what is the difference between third generation and fourth generation formulas? Anybody? What's the main difference between third generation and fourth generation formulas? It's simple thing. The fourth generation formula takes into account a term ELP, effective length position. What is that effective length position? You have taken the cataract out, आपने आलू का सारा गूदा तो आलू का छिलका बचा लिया, छिलके में नया लेंस रख दिया. In which you have implanted the new intraocular lens, the dimensions of the new intraocular lens according to the company, the material, the design will be different, and the capsular bag contraction and closure of the capsular bag will be different for all individual cases. So this capsulo-lenticular interaction with the capsular bag will finally determine the position of position by calculating the anterior chamber corneal diameter, by calculating the lens thickness. If a machine or a formula takes into account the corneal diameter, the anterior chamber depth, the lens thickness, this is fourth generation formula, and it will predict better effective lens position postoperatively, thus leading to better accuracy and less refractive surprise postoperatively. In fourth generation, there is Hedges, Holiday 2, Olsen. The Olsen formula is available online, and there is another. Take your calculations and fill those boxes online and get the printout. And if there is previous keratorefractive surgery, the best formula for that is ASCRS calculator, American Society of Cataract and Refractive Surgery calculator. I have given the link there, and very soon we will make these PPT slides as PowerPoint presentations available online as well. So you will be able to download these slides and get the necessary information you like. http iulcalc.ascrs.org. This is the best formula for post-refractive surgery patients. Whatever information you have will help. So I think Dr. Suhail may have explained it all well. What is steeper meridian and how you can plan your incisions on the steeper meridian. You see, and our tendency is generally to place our incisions above the 3 and 9 o'clock position. Generally, we don't place incisions if it is not specially indicated below 3 and 9 o'clock, because the tear lake is accumulated along the lower lid and jumping of some. I place inferior incisions only if I need some astigmatic correction. Otherwise, tendency is to place your Phaco and your second incisions above the horizontal line. This is how you can vary your incisions according to the steeper meridian. And then you can vary the size of your knife as well. For example, if there is difference between K readings of about knife, instead of a 2.75 millimeter, 3.2 millimeters knife will relax it between 0.5 to 7.5. Keratometric reading is less than 1 diopter, then you need to be astigmatic neutral. How can you be astigmatic neutral? We'll be discussing in next part, that is wound construction. With this, we move to our second part. हेलो, ये भी चलता है? नहीं? कोई नहीं चलता, कोई नहीं, I'll manage. तो ये वीडियो है रोल ऑफ नॉन डोमिनेंट हैंड इन फेको कैटरेक्ट सर्जरी.
بسم الله الرحمن الرحيم.
Title of this video presentation is Role of Non-Dominant Hand in Phaco Cataract Surgery. Venue, I Department, Central Park Medical College and Wapda Teaching Hospital Complex 210 Phaco Road, Lahore, Pakistan. The author carries no financial interest in this video presentation. The background, one of the major things a Phaco surgeon learns over time, is use of other instrument which is generally held in non-dominant hand. However, after getting inspired from one of the eminent local Phaco surgeon, and reviewing the Phaco surgery technique on the net, the author realized that non-dominant hand can play a more vital role in the whole surgical procedure and its outcomes. Purpose: to elaborate a safe and effective use of non-dominant hand in Phaco cataract surgery. The stress is on the fact that it can be learnt over time as explained in this video presentation. General role of non-dominant hand in Phaco cataract surgery is to hold the second instrument. We use our second instruments to help hold back and protect the posterior capsule, to manipulate nuclear pieces into the Phaco tip, and to rotate, crack, and chop. We use the shaft of the second instrument to assist with eye position. We take for granted that our second instrument will not wander off and become an element of destruction, wreaking havoc on the iris, anterior capsular rim, cells, or posterior capsule. Right-handedness. 70 to 80% of the world population is right-handed, rather than left-handed or any other form of handedness. Left-handedness. 10% of the world population is left-handed. Mixed-handedness, also known as cross-dominance, is being able to do different tasks better with different hands. Ambidexterity is exceptionally rare, although it can be learned. A truly ambidextrous person is able to do any task equally well with either hand. Those who learn it still tend to sway towards their originally dominant hand. Let us see what you can do about it. You can practice as much as possible. Try using your non-dominant hand during the day for daily activities such as brushing your teeth, combing your hair, locking and unlocking doors, eating with utensils, opening screw-top containers, and picking up small objects. Fine motor skills, such as writing and drawing, are usually reserved for your dominant hand, but attempt these with your non-dominant hand. Some even advocate writing from right to left in an effort to stimulate brain development. In this video clip, my right dominant hand is operating, and the left non-dominant hand is providing the equally important supportive services as explained in the previous slides. placement of main Phaco incision, capsular axis, rotation of nucleus and Phaco emulsification itself, were all carried out by right dominant hand. Paracentesis for second instrument was performed by left hand. My both hands complemented each other, and worked together, during whole of the procedure, for safe surgical outcome. Non-dominant hand again came into action for irrigation aspiration of remaining lens matter. This video clip shows the non-dominant left hand doing the main job, like placement of Phaco incision, holding the Phaco hand piece, and implanting the intraocular lens. My right dominant hand is acting like an elder brother, and coming for rescue and support wherever needed. Especially hydrodissectio and capsular axis are the domains of right dominant hand for me. Whenever the need arises for performing some delicate maneuver, like completac the capsular axis, the right hand comes into play, and supports to stabilize left hand to complete the procedure successfully. Phaco head piece was also operated by non-dominant hand through temporal incision. Again my both hands complemented each other, and worked together, during whole of the procedure, for safe surgical outcome. Intraocular lens implant was also carried out by left hand. Once a surgeon gets hold on judicious and safe use of non-dominant hand, almost all of intraocular instruments can be alternated between two hands. Placement of incisions on steeper meridians, using Phaco hand piece, irrigation cowler, and injection of IOL, may all be carried out very easily without cumbersome change of surgeon's sitting positions. The conclusion, being ambidextrous is a great blessing in any kind of surgery. However, point to make in this video presentation is that it can be learnt over time to useful effect for better patient outcomes. Fully formed surgeons take use of their non-dominant hand for granted.
In the end, we summarize our discussion. Always have repeated A's and K's. Always have a tangential look while applying an A-scan probe on the cornea so that you don't compress the cornea. Always compare two eyes and do have a finalized refraction if already operated. Do document keratometric axis and plan your incisions on the steeper meridian accordingly. One needs to be very vigilant if not able to correct pre-existing errors, to at least not induce it. We believe it plays a very vital role in final visual outcome after Phaco cataract surgery. And again we come to our Urdu poetry. है गुले नाज़ां चमन की दास्तां हमसे सुनो, ताक में हैं बिजलियाँ बर्बादियाँ हमसे सुनो, जाबिरों से आमिरों से गासिबों से साज़बाज़ मुजरिमाना सरगुज़श्ते क़ाज़ियाँ हमसे सुनो.